And here's my last audio check. Thank you, Matt. Am I sounding okay today? All right, we'll
Sound
take
good to
that.
me.
All right, thank you. All right, so I get to present today on a course you guys can all read, Risks and Responses to Hospice Medical Review. I am, here we go, Joe Ozentoski. I work for Gateway Home Health Coding and Consulting. Longtime nurse, long time in home health and hospice. Primarily right now, I'm dealing with types of medical review from various Medicare contractors and then appealing denied claims, as well as trying to improve hospice documentation to prevent denials. So it's a pretty busy time. As you'll soon see, there's quite a bit of Medicare review occurring because when Medicare gives money or pays money, then Medicare also likes to pull money back or determine if payments were appropriately made. So I have quite a few slides today and a lot of information on the slides, so it's very good that you'll be able to receive a copy of this after to pick up pieces. So I just want you to kind of follow along with me as I highlight the risks of medical review and some response options that you have and some actions you should take if you are subject to medical review. So overview of today is, of course, since the public health emergency has officially ended, that all types of medical review have occurred. Now, when I say medical review, I'll explain that in just a little bit, clarifying it more. But basically, just keep in mind this as a concept that there's multiple Medicare contractors that are out there and other types of contractors as well that are actually looking at the medical record for accurate claim payment. Now, most hospices, you have a QA program, you're looking at records ongoing, you're doing internal review processes, but you're primarily focused on, most of them are focused on survey compliance, which is, of course, extremely important, conditions of participation compliance. But along with it runs the risk that a medical review can come along and then deny claims. And therefore, you've lost the money that you have accumulated for the work you've done, which is not a good outcome. So a key to a successful outcome from one of these types of reviews, which I will touch on briefly or momentarily, is really you can get targeted probe and educate review, UPIC audit, recovery audit contractor review, SMRC review is really the key to a good outcome. Ready for this? Is compliant clinical record content. So your staff need to know what the rules and regulations, what applies in your physicians, medical directors, what needs to be in the record, and then document that in your charting so that if any of these types of reviews are actually triggered, and they're all basically focused right now with a few exceptions, that you'll keep your money that you have booked as revenue. So I touched on the issue of surveys versus reviews. Now, surveys commonly occur, of course, or regularly occur. This is usually done by either a state surveyor or a deemed status surveyor, a site visitor. And this determines your compliance with the conditions of participation, the COPs, under section let's see. You have the COPs under 42 CFR 418. But anyway, conditional participation compliance. If you have an issue, you'll be issued, or a problem, you'll be issued an L tag, and then you have to do a plan of correction, follow up, these types of things. It also looks at your agency systems, your infection surveillance, your personnel, compliance, documentation, all these different components of operating your agency. It is basically a documentation and record review, although it also specifically does include home or site visits and then interviews with staff and patients. So a survey is to the conditions of participation, but it is not primarily or objectively a financial issue that can come up to an agency or be presented to an agency. It's compliance to be a hospice provider. Whereas medical review in its various forms is done by CMS contractors, not by CMS itself. Super rare. I have gone through some federal OIG reviews, but really primarily it's contractors. And then it determines compliance with payment and coverage requirements, meaning did the service you got paid for, was that reimbursable service and you should remain paid? So it's really a financial based or financially focused review. It determines if payment was correct and is primarily done by looking at documentation. There's rarely any site visits or even staff interviews for the most part. So medical review is really a financial risk to your agency. So compliance with good documentation practices and charting practices is really paramount to getting a good outcome from a medical review occurring. But understand there's a significant difference. You need to comply with both, but medical review is a financial issue. So who's looking at these records? So to give an overview of this as well, we have the Medicare Administrative Contractors. There's 3 of them, and there's 4 regions. National Government Services is either Jurisdiction 6, which is primarily in the Midwest, also Arizona or California. And then also there's Jurisdiction K, which is primarily just a few New England states. Then there's the Big E Palmetto Government Benefit Administrators, Jurisdiction M or JM. They're Texas, Florida, mid lower country in the country, and then Southeast. And then there's CGS administrators, who kind of splits the difference between NGS and Palmetto and runs down the middle as Jurisdiction 15. Again, there's 3 administrative contractors, 4 regions. These are the primary drivers of hospice medical review right now, the MACs. There's also, if you're dealing with the Unified Program Integrity Contractors, you're probably not having a good day. There's 4 of those, again, geographically located. Cularent is the Southwest jurisdiction. If you're in Arizona or California, you'll deal with Cularent. If you happen to be in the Midwest, Ohio, Michigan, you'd be dealing with Covent Bridge. If you're Southeast, you deal with Safeguard Services. So they basically split up the country into UPIC territories. These are significantly more detrimental to an agency if you trigger a UPIC audit. You also have Recovery Audit Contractor, the RAC. There's only one for the whole country for home health and hospice. It's called Performant Services. If you go on their website, it's Region 5. Basically, they do a low level of review, but you have one Recovery Audit Contractor. Then there's also a group called the Supplemental Medical Review Contractor, SMRC, sometimes called SMRC. I don't use that abbreviate or that phrase. It's Noridian Healthcare Solutions. This does basically, it focuses on Medicare review as given by Medicare, meaning Medicare in its general sense, the highest level looks and says, well, let's look at this particular problem, issue, or topic, and sends the SMRC out to do multiple reviews on that type of service, as opposed to the other types of reviewers that are occurring. You can also occasionally have a cert review contractor audit, although again, I'll have the risks on each of these on subsequent slides. So understand the takeaway from these 2 slides is really there's a lot of medical review contractors out there looking to evaluate if you've been properly paid and take money back if they think you haven't been. So there's also 2 things which are really hot in the news right now for hospice, but I'm putting these in here even though one of them is not a financial issue. There's the Hospice Special Focus Program. And then, of course, as you can all read, the Provisional Period of Enhanced Oversight, PPEO. And if you haven't figured it out by now, if you're dealing in this area of service, you're dealing with acronym after acronym after acronym, right? Everything has a title on it. Now, the Hospice Special Focus Program is basically looking at what are deemed to be poor performing hospices based on select quality indicators and a super secret algorithm, or an algorithm that CMS will look at certain hospices and then determine, well, they need additional scrutiny. And understand that the special focus program will actually increase hospice visit or hospice survey frequency, but it is not specifically a financial focused program. Even though it's a special focus program, it's basically saying, we're looking at seeing if you should continue to be a hospice with having increased survey frequency. They could impose fines or actually suspend your reimbursement privileges or take over temporary management. There's all sorts of bad things that can happen if you fall under the focus of the Hospice Special Focus Program. But it is not a clearly financially based evaluation of quality of services, quality of payment for services. There's also the PPEO on this slide here, which is 2 types of agencies or hospices are subject to this. New providers will be subject to ongoing or more frequent medical reviews because of the significant increase in the new hospices under the pandemic time period, excuse me. This program is for newly certified hospices as well as change of ownership. So if you happen to have a new hospice since July 1st or 13th, 2023 in Arizona, Nevada, California, or Texas, you will probably or almost 100% be subject to this, and you'll be getting basically medical review. This is ADR based. This is medical review, looking at is payment appropriate for services. It is basically purely financially based, so that Medicare is looking to not pay money and then have to find it later or take it back. They're looking to prevent payment of improper services. There's also, if you had a change of ownership, this would be for nationwide, not just in these states, you may be subject to hospice PPEO reviews since that time period. So all this reviews occurring. Now let's look at the risks and what is actually the focus of review. So JM here, so this is actually Palmetto Government Benefit Administrators. They post on their website, Hospice Targeted Probe and Educate Active Medical Review List. So Palmetto's really good that they actually do put their review topics up so you can get some idea of the types of claims which may be subject to scrutiny. So first of all is benefit sharing. Now it's interesting that they use benefit sharing as the topic. This is from their site, and then they describe it as the claims submitted for hospice services benefit sharing. The nearest I can come to this is that if there is another Medicare provider also who is making payments in relation to this beneficiary's MBI number, then you run a higher risk of medical review. Most commonly, these would be beneficiaries residing in nursing facilities. So if you have so as opposed to being at home. So if you have a patient in a facility, then you run a higher risk of getting medical review of that particular patient. This is in hospice or under Palmetto GBA area, again, primarily Southeast United States. Also, general inpatient level of care, looking at review of inpatient claims for hospice care greater than or equal to 7 days. So if you're doing GIP level of care for 7 days or more in a skilled nursing facility, inpatient hospital, hospice facility, long-term care hospital, inpatient psych facility, then these claims will also be subject to increased scrutiny. Then, of course, if you're a new hospice provider, you can get also increased scrutiny. Also from Palmetto, they look at revenue code 0651, these ones listed here, which are basically all types of service, routine, continuous home care, respite, and GIP, and basically looking at length of stay. So if a beneficiary's been on hospice service more than a year, they have, no matter what type of home care, or I'm sorry, what type of hospice is provided, they're subject to increased scrutiny of review, possibility of increased scrutiny. Benefit sharing, again, for basically routine level of care. Again, if there's multiple Medicare providers that are billed for that service, you might run a higher risk of medical review on them. Then GIP, again, actually looking at continuous care home review submitted for hospice services. Actually, well, I'm sorry, the title on this one here should refer to continuous home care services. Why would you think you'd get a higher review of GIP and continuous care? Because they're getting paid more. And if they're getting paid more, then there's more risk of financial loss to Medicare. So Medicare puts additional scrutiny on it. Also, hospice or Palmetto's looking at non-cancer length of stay, looking at primarily these would be dementia and failure to thrive beneficiaries who have a long length of stay, and therefore these are subject to increased scrutiny. These are Palmetto's posted areas of focus review. Targeted review, I should say more appropriately. Whereas jurisdiction 15, this is CGS administrators as another example. What are they looking at? Length of stay with non-cancer diagnoses of more than 730 days. They're also looking at GIP level of care, 7 days or longer. They're also looking at if you're a new provider who have been submitted at least 50 claims, and then length of stay in this nearly on a year to just over a year and a half period of time, basically any type of service. So basically they're looking at longer length of stay and non-cancer diagnoses, GIP level of service. You're kind of seeing a trend on what the reviewers are focusing on or targeting. NGS, of course, sets themselves apart in that they don't like to really post their target or focused areas. You have to kind of guess what they're targeting. Although I have a pretty good idea looking at what Palmetto and CGS are doing. NGS does post that they're running ADRs or targeted review based on these areas and the codes here, these 5CQC2 and 5WQC2, that will be on the ADR you receive. But basically, they're looking at, I'm going to say, long length of stay, GIP level of care, pretty consistent. And then NGS here does actually post and say what the primary denial reasons are within these individual medical review reasons, meaning that when they do this first Q code review, whatever triggered it, that the primary reason they're denying claims is because they're saying certification is not present, the benefit election was not signed timely. These are technical things that are easy to deny, or no terminal prognosis supported. So basically, I think that's a length of stay issue regarding the first issue. And the second one, looking at the denial reasons, again, invalid notice of election, does not support terminal prognosis again. They're probably looking at GIP and long length of stay, but this is pretty much the best we can do. Palmetto is really good about posting detailed content, what they're looking at. CGS is pretty good. NGS has never been that way. So hospice, one of the titles today is actually risk review. Well, here's looking at some risk. Under targeted probe and educate. First of all, if you're getting this review, you are targeted. Probe and educate, meaning they're going to pull claims, ADRs are going to be issued, look at them. You are at a high risk if you are providing substantial amounts of GIP level of care, especially if you're keeping that beneficiary or patient on GIP for 7 days or longer. That's a very high risk for generating a TPE. And if your overall GIP percentage is high, or getting near the limitation, the 20% limitation, then actually you run a high risk of getting a TPE, targeted probe and educate review of GIP services. Also, under targeted probe and educate, it's high for long length of stay, especially for routine level of care patients who are residing in facilities. They're basically looking at if you're double dipping, if you consider to be double dipping, because the facility should be able to care for their basic needs. You have a medium risk for certain diagnoses-based reviews on routine level of care. These would primarily be cancer diagnoses, certain other types, but also these would also include home care provided at home for routine level of care. So medium risk from that. But your biggies here from the targeted probe and educate, from the administrative contractor, GIP, 7 days or longer, and then patients who reside in facilities. Those are your higher risk medical review claims. So therefore, we need to be increased scrutiny of our charting in relation to those patients. Unified Program Integrity Contractor, if you triggered one of these reviews, if you have, again, a significant number of GIP cases, if you have a pattern of admitting patients on GIP when they come on hospice and then transitioning them off, if you're keeping patients on service for 10 or 14, or if I've seen 27 days on GIP level of care, that can raise the antenna of getting a UPIC, or Unified Program Integrity Contractor review. So they're really focused primarily on GIP level of care because of the amount of money that's paid out on GIP care. Also, UPIC risk is high if you're a new provider, just because Medicare does not want to pay and chase. They want to prevent the improper payments from being issued. And new providers in certain geographic areas with ownership overlap with other entities, there's all these factors that can figure in, are generating significant UPIC activity because Medicare wants to look basically immediately upon service provision if you exist and if you're providing appropriate care, and not have to pay the service and then pull it later on review and then deny it. Supplemental medical review contractor review right now, they have no active hospice issues going that I was able to find, so it's very low risk from them. Recovery audit contractor review, very low. If it is, it's going to hit either the GIP or continuous home care levels of review. It's probably only going to be 1 or 2 claims, very low financial risk and very low risk of triggering a review. Now the preliminary period of, provisional period of enhanced oversight is very high. If you were a hospice, again, as either a new hospice in one of the 4 states mentioned, or if you had a change of ownership since July of this year, moving forward, you have a very high risk of getting oversight, and these would be increased ADR reviews. So, denial considerations. Medical review follows billing. So, understand that when an ADR is issued, right, they will pull, because you bill basically on a calendar month. So they'll pull all the service in a calendar month. So if it's routine review, then it'll be whatever days you billed at routine level of care in that calendar month of service. They'll also pull days billed at higher paying levels of care, continuous or GIP level of care. So basically is you submit a bill, and then what's always going to be in question is you billed that amount of money for that level of care for those services in that month. And that's what you're going to be disputing or fighting if you have to deal with any appeals. In that it's really complicating things sometimes because the calendar month billing does not correspond to benefit periods. I mean, basically it never does. So you're taking a slice out of your continuous service provided, not continuous home care, but the continual service, and then looking at that. So therefore you'll be probably needing to take content from outside that calendar month to help support your service being provided as reasonable, necessary, and appropriate. So Denial considerations. Denial can be based on defective admission documents, notice of election, certification of terminal illness, and that risks denial of all your hospice service. It can also be based on terminal prognosis not supported. That risks denial of all hospice service from the date that they initially deny it until present. As long as that patient's on service, the probability is you will get denied, ADR denied on all service. Based on no terminal prognosis. It also, denial is frequently based on unsupported higher level of care. However, the good news, if you want to call any good news, is that I have yet to see a higher level of care, GIP level, denied that did not revert back to routine level. So they're not denying that the patient wasn't needing hospice. They're saying they didn't need that level of care of hospice. So that's generally a positive out of that situation. They also deny for non-technical reasons. Again, as I noted, if they issue that, it'll continue until the patient's discharged or dies, in which case then magically a service 6 months prior to death may then flip to payment. But basically understand this. If you keep a patient on hospice service after you've been issued a no terminal prognosis denial, you are running a risk of never being paid for that patient unless they die. And until you discharge them, or they have a significant provable declining condition, which is noted, and that's usually not the case in most of those. Understand, capitalize on the bottom. All of these denial considerations impose a severe or significant financial burden on you as the provider. So when I look at claims from hospice and reviewers, I look at two main time points or two areas here: admission documents, which include the notice of election, certification of terminal illness, basically establishing the hospice need. Face-to-face encounter as appropriate every time there's a 60-day benefit period. Admission assessment is a baseline, and then plan of care developed from these findings. And then ongoing, the charting, documentation, and support for service shifts to the IDT, IDG. I will use IDG subsequent to this. Interdisciplinary group meeting content, updates to the plan of care based on changes in condition. Again, the continuing certification of terminal illness, face-to-face encounter with recertifications. The actual visits themselves, which surprisingly play a minor role overall in hospice compliance and payment. And then any changes in level of care. And then, of course, death, discharge, or transfer when the beneficiary patient comes off service. So important medical record documentation to keep in mind. This is kind of like the response to the documents you need to consider. Is your charting good, or is your charting supporting your benefit the level of care? Is your charting supporting your billing? Of course, the beneficiary election statement, the election statement addendum, if requested, there's very specific content in relation to requirements here. The physician certification, recertification, super important. The physician narrative, directly linked to the local coverage determination content for that particular administrative contractor that's given to you. Your basically IDG notes. If you have your inpatient GIP medical records, meaning what were you doing to control this uncontrolled symptom that was developed, which resulted in the higher level of care. Then, of course, you have the hospice plan of care, which encompasses all their palliative needs. Then you have the specific nursing notes in the initial assessment, any other physician progress notes, orders, changes to the plan of care, all your other caregiver discipline notes. Face-to-face encounter, tremendously important if documented in relation to the LCD guidelines in relation to that patient, the guidance given on terminal prognosis determination. Advanced beneficiary notice, just from a financial payment responsibility, liability issue. Also, your continuous home care charting. What were you doing as a hospice to address the symptoms which were uncontrolled, which resulted in continuous home care? And then a missing piece frequently is the facility documentation of GIP level of care, where they will probably torpedo your excellent charting by saying the patient is having no problems and is doing fine, even though they're on day 3 of GIP level of care. So all these are important pieces of document to consider in your record for compliance for payment purposes. Now, key coverage payment documents are also going through these again in a little more detail here. Notice of election, certification of terminal illness at admission, each benefit period. Every 60-day benefit period has a face-to-face encounter that includes narrative related to the local coverage determination requirements. You have your IDG notes, you have your plan of care, both initial and updated with changes. Again, if you have a higher level of care, GIP continuous, documentation of uncontrolled symptoms, and what actions you took to address it. All of these must integrate the appropriate hospice LCD, local coverage determination content. And then also note that only a physician may certify hospice terminal illness, not a non-physician practitioner. Um, so charting compliance, these are again things that you should be looking at and considering how to get a good documented chart at the time service is provided so that in case any of this review is triggered, that your claim will be payable or remain payable. So at admission, ensure that all your technical items are complete. Technical items are, do you have a notice of election, CTI, face-to-face encounter completed, present, has all the required components on it, and the hospice election statement and addendums present. So at admission, you generate a baseline hospice appropriate status. And then during care, IDG and visits, palliative interventions, you document what you did for a changing condition to maintain their palliative status or maintain or alleviate the symptoms and findings present. And then at recertification, it comes up again as a key component to say, what is driving the reason that they're on hospice? Why are they continuing to be appropriate to have a reasonable expectation that if the disease takes its normal course, that within 6 months, this beneficiary will die? And then face-to-face encounter is an immensely important document, and I see these failing all the time for content of face-to-face encounter. And also recognizing if the beneficiary is no longer appropriate for hospice, discharge. Do not keep them on to think, well, they might decline in the future. If you've established a long pattern that they are not showing progression or declining condition, then you must really consider discharge. It's not a problem because you can bring it back on when you've established they are appropriate, but keeping patients on too long, remember back to those TPE, target, probe, and educate topics from the administrative contractors, length of stay is significant in there. So just keeping a patient on service and hoping that they're going to decline is not a valid hospice service. Now, notice of elections needed for all claims. If it's incomplete, invalid, and timely, you will lose all your hospice-related service that you provided to that patient. This is especially a problem when you get a longer-term patient that gets ADR'd, the claim gets ADR'd, and then they go back to the notice of election, find a problem with it, and then deny all the service. So hospice, Medicare does tell you, there's no form they require, but they do tell you the content that needs to be there, and I've listed much of it here, identification of the hospice. All these parts need to be on it. Do not, there are examples, samples out there. Do not really mess with this form very much. I'm telling you right now, I dealt with one hospice that thought that they could write a better notice of election than the examples given by CMS and resulted in removing parts that were required, and they got denied, and I couldn't help them. So all these parts, CMS does specify, Medicare specifies what needs to be on there about acknowledgement and the effective date of election, which cannot be backdated. These parts need to be on your notice of election to have it be compliant. And this is a baseline. If you don't have a valid notice of election, you cannot have any hospice service paid on that patient. Some more required content, again, as I was going through it, signature of the patient representative, information about being holistic, comprehensive hospice benefit, statement that there may be services that aren't covered, notification of the beneficiary's right to request an election statement. All these things need to be there. CMS does tell you what needs to be there. Ensure they're there, get that form compliant, get it signed, dated appropriately, and you'll be good to go with your notice of election. Another key document is generated at start of care or admission, I should say, and then at each recertification for continued benefit periods is your certification of terminal illness. And again, CMS does specify certain requirements, timelines on it. A complete CTI must include a statement of medical prognosis, clinical findings supporting the life expectancy. And they say clinical findings, they don't mean things like decreased appetite, decreased mobility, these types of things. They actually want clinical findings when appropriate. I'll touch on that in the LCD content later. Signatures of physician, date signed, benefit period dates on it. Yes, it does need to include the dates that it applies to. The initial certification must, of course, be include the patient's attending physician if applicable. A brief narrative explanation of clinical findings. You see this twice now. Clinical findings are important to support hospice appropriateness, and then an attestation if appropriate. Certification under, here's a restatement again, no one other than basically a physician can certify or recertify. Nurse practitioners and physician assistants cannot recertify or certify as terminally ill. And then basically it comes down, you need to have an MD or DO. I guess a DPM could do that, but I've never seen that. Anyway, if a medical doctor must do the certification. Now, clinical findings in the CTI that I've mentioned it twice before. Here it is again. They should include things like what signs are present, objective measurements, what symptoms are reported, the subjective component, what lab tests may be appropriate, what weights are there. If you're not getting weights, are you getting anthropomorphic measurements, mid-arm circumferences, oral intake, more than saying poor, good, fair, or percent. I mean, some specific content, how many calories, what are they eating, what is the consistency of their diet, these types, or their ordered, ordered diet, are they on a altered consistency due to swallowing issues, these types of things. And then local coverage determination, specific findings need to be present. Much more so than just subjective statements of, well, they're getting worse, they're not doing well, they're sleeping a lot, and therefore they don't need, or I'm sorry, they need hospice services. So you want measurable content because these are the items that will be compared over the benefit periods in any medical review to determine if there's a change in decline in condition. Signatures on the certification of terminal illness by the physician, the date signed, periods covered. Again, location for narrative is important. What do I mean by this last bullet point here? Is that there is a brief narrative that is required as of 2009. So we're well into this requirement being present, that there must be a narrative that supports the clinical findings, that supports a life expectancy of 6 months or less, maybe an addendum to the certification forms. If you do make an addendum, ready for this, it must be located directly above the physician's signature. This is one time Medicare actually says where documentation needs to actually be located in the chart, directly above the physician's signature. So it's very clear that the certifying physician is using this CTI narrative finding to support terminal prognosis. Must include confirmation that the physician composed a narrative, may be dictated, but must reflect the individual clinical circumstances and cannot contain checkboxes or standard language used on all patients. So it has to be a written narrative, brief narrative to support hospice appropriateness. I mean, in a way, you could probably get away with a few check boxes, fill in blanks, but the vast majority must be really a dictated narrative content to support terminal prognosis. Face-to-face encounter, basically it says, here I put it needed with the third benefit period and after for 60-day benefit periods is an easier way to think of it. Timing must be no more than 30 days prior to the third benefit period, could be on the first day. Basically, they have to be an attestation that the encounter occurred by whoever completes it. And this face-to-face encounter may be completed by a non-physician, right? It's not the certification of terminal illness. It's really the support for the certification of terminal illness. So an NP or a PA can actually sign this and then basically attest that the findings were provided to the certifying physician. It's signed by the physician or nurse practitioner who performed the encounter. So hospice common certification errors, including predating of documents, not having two physicians if there is an attending at start of care. Narrative is not present at all. The attestation component of the narrative is missing. They're not having vertible certifications by both medical director and attending physician. There's no signature on it. They're illegible, not dated. Not clearly stating the dates of certification period that it encompasses. All these can make an invalid certification, and that basically makes all your subsequent hospice service non-payable. So a certification of terminal illness is an immensely important document. Moving along to an IDG component of compliance and preparation. Of course, you have to have at least every 15 days. Most hospices do it every 14 days. Really, it establishes the plan of care along with the physician. You have your goals for treatment, your coordination of services, changes of plan of care are reflected here. Incorporate whenever possible local coverage determination requirements and indicators that are demonstrated by the patient. Attendance documentation has to be kept. Key item is to show changes over time with the patient and a summary of those changes of condition or decline, right? An IDG is basically every 2 weeks and shows a nice progression. Individual visits may show very little change in condition, but every 2 weeks you might see a change in condition. And then every benefit period, you should see some change in condition for the most part to support hospice appropriateness and progression. So Let's go a few regulatory components to consider here. Hospice, unlike home health care, as an example, actually has a rather sparse um, Medicare compliance part, meaning the Title 42, Section 418 are your hospice rules. And basically looking through these, there's not a lot here. I've listed them for you. Certification, terminal illness, the election, admission to hospice, discharge. Not a lot of actual stuff that'll get you denied here, except from the technical compliance parts that I covered with the CTI. Then you have the Medicare Benefit Policy Manual, publication 100-02, Chapter 9. Not a lot of content here either. Basically goes over general hospice requirements, certification election requirements, timing and content of what should be on your certification, how to elect, revoke, and discharge, what are covered services in a general sense. Then continues with what are physician services, counseling, and then has a little section on inpatient care, what to do with hospice aid, role of therapy in hospice, continuous home care, respite care. There's not a lot of actual stuff that'll get you denied here, but it's important that you have a firm understanding of what the baseline requirements on the Medicare Benefit Policy Manual are and the conditions of participation. So local coverage determinations, this is really what'll make or break you in a hospice medical review. And this is why preemptively putting this content into your records is the key coverage requirement, the key to keeping the payment for services as well as administering hospice. I've listed them here for the 3 administrative contractors. You can find them all in the Medicare coverage database. The website's there. Understand that Palmetto, being unusual, of course, has 7 of them here, local coverage determinations. NGS has 1, CGS has 1. I'm going to tell you right now that the Palmetto GBA LCD content, this is where it actually fleshes out the incomplete national coverage determination content. So for liver disease or renal care or Alzheimer's or cardiovascular cardiopulmonary conditions or adult failure to thrive, this is where you will find content of findings, signs, symptoms that'll support your service. So the content from these documents is what you need to look for and reflect in your charting and your certification of terminal illness and your face-to-face narratives to get your claim covered on any medical review. And I'll tell you right now, again, Palmetto ones, they have a lot of them, but they don't have a lot of content in it. I would highly recommend as guidelines to take either CGS or NGS, who lays out as one LCD, and they lay out in it's a very easy to follow process. It lists signs that are relevant, symptoms that are relevant, specific disease findings that are relevant. And if you can chart those in your record, you will come out far better off in under medical review. So common hospice documentation issues are IDG notes contradict face-to-face narrative findings, pretty common. The IDG basically finds nothing. The face-to-face has all sorts of problems on it. IDG notes do not address terminal illness prognostic findings. They're just saying the overall condition without looking at the LCD content to think what signs, symptoms are present, progression, decline in activities of daily living function, the progression in Karnofsky of palliative performance scale components, weight loss, these types of things. These should all be reflective in the IDG as well as the face-to-face narratives. If you have a level of care for continuous general inpatient, documentation issues are, is the level of care for which you're billing appropriately documented? And what commonly comes up under the GIP level of care is that the facility records are either present and contradictory to your hospice records, or they're not provided to the reviewer, in which case the reviewer has no idea that there is still an uncontrolled condition needing a palliation of services. Clinician visit notes do not address terminal illness prognostic findings. They don't all have to in great detail, but they should address it in some way. If you're seeing a beneficiary or patient for dementia, the hospice and each visit should have some cognitive findings present to support that there is a declining condition or a significant impairment of condition. Visit notes do not reflect LCD prognostic findings, or they contradict certification face-to-face narrative findings. The visit notes do not identify terminal diagnosis relevant findings. They generate a lot of things like patient were received sitting at home with feet up on stool, watching television, talking to daughter. I don't really care about any of that if I'm a reviewer. I want to know in relation to their cardiopulmonary condition, what is their oxygen saturation, what is their limitation, what is their respiratory status, these types of things. And the visit notes are inconsistent between disciplines, especially social service and spiritual care, who are miracle workers apparently, because the beneficiary and patient is talking and reciting all sorts of things, and the nurse goes in and they are barely able to know where they're at. They're disoriented. So consistency between documents, visits is important. Other common hospice coverage issues: principal diagnosis not coded correctly. This is becoming more of an issue about the diagnosis selected for billing purposes for terminal prognosis. Comorbid secondary conditions are not documented or not supported. Level of care changes do not record the date, time, and reason why that higher level of care was needed, and then why they came off service, what prompted that. GIP level of care, if you're transferring the beneficiary to that level, you should have a precipitating event. What was the onset of uncontrolled symptoms or pain? Interventions tied in the home have been unsuccessful at controlling it. What was tried? Why are you putting them on GIP care? And then ongoing care should include frequent evaluation by a physician, nurse, medication adjustments, IV medications. Why do they need this higher level of care should be very clear from the record, not that they stabilized on day 2 and you discharge them from GIP on day 14. Continuous home care supported documentation does not, for denial purposes, right? This is why the claim would be denied, show they actually needed the higher level of care and describe the patient's response to care. It's very similar to GIP level. What was being done to address the reason why they're on that level of care? So if there is stabilization of function, if a patient improves or stabilizes sufficiently over time that there's no longer a terminal prognosis, they should be considered for discharge. And then they could be brought on hospice again later when they do exhibit that. So that's fine. But just keeping patients on service is not appropriate for a medical review purpose. That's why the length of stay is such a focus of review. On the other hand, patients in a terminal status who originally do qualify but stabilize, who still have a reasonable expectation of decline, can remain on hospice. It all goes back to charting the LCD content on the certification terminal illness, the face-to-face encounter, and showing it within the IDG visits and IDG conferences, and then the notes themselves. So LCD coverage abstract. The local coverage determination, this is taken from one of the local coverage determination general phrasing. I put it in here because it helps explain really that terminal prognostication is not a scientific fact. It's basically use the LCD as a guideline to identify the Medicare beneficiary whose current clinical status is anticipated to progress so that they have a life expectancy of 6 months or less. So clinical variables as well as specific diagnoses can all factor into this. Some patients may not meet these guidelines, yet still have a terminal prognosis, and other ones may have all these and not be. So these are, again, the whole takeaway from this slide is these are guidelines. So the general application, again, taken from an LCD, which kind of spells it out nicely, is that basically coverage for hospice care for patients not meeting the criteria in this policy, meaning the LCD, may be denied. And then again, some patients may still have findings that are not in there, which can support it, But basically, understand this. This is the key because there's so little national coverage requirements for GI, for basically anything of hospice, right? Medicare itself in the 42 CFR 418 or the Medicare Benefit Policy Manual has very little prognostic content. It's all sitting in the LCD. Therefore, the LCD becomes the de facto coverage. They're called guidelines, but if you don't meet them, then you're probably going to be denied service if you're not showing they're appropriately generated on that patient. So hospice charting. So what about these indicators for terminal diseases or progression? So we have indications. It's really broken down in 3 parts. And again, this is my suggestion to take either no matter what state you're in, take the CGS or the NGS LCD for terminal prognosis, and then go through that, because this will break it down into these 3 sections. It's very easy to follow, gives you lots of findings to look for and document in your records. But going back here, prognostic indicators. A patient will be considered to have life expectancy if they have what are called non-disease specific guidelines showing a decline in clinical status. And then do they have a baseline problem or level of function being shown in part 2? And then part 3, you take the first 2 sections and then add on the disease specific parts, meaning there's these prognostic indicators that apply to all patients, and there are signs and then there is a low level of function that's there, and then there is a change in these signs over time and findings over time, which support terminal prognosis. And then you can also link them with a disease-specific guidelines. When you put all this together, it gives a nice picture that this person is still giving a reasonable prognosis of 6 months or less. And then you also want to include all comorbidities that may contribute to the overall condition. So part one, when I mentioned the 3 parts here, is that patients will be considered a life expectancy if they're showing an evidence of decline in clinical status based on guidelines. And then basically you need to establish a baseline finding and then follow-up determinations to be reported. So you need to, again, at admission, assess all these findings, and then basically at minimum, every certification of terminal illness, every recertification, you need to go back and revisit these. If you're doing that, then you'll have a nice every 2 or 3 month comparison of findings which are deemed to be appropriate for determining terminal prognosis. So these changes in clinical variables apply to patients whose decline is not considered to be reversible, and so therefore it should be basically a one-way path for the most of these. If they get better, then that's an indication to consider that they may be appropriate for discharge. So progression of disease documented by worsening clinical status. Here's some examples of clinical status. Weight loss of 10% in prior 6 months, not due to reversible causes, decreasing anthropomorphic measurements, mid-arm circumference, not due to reversible causes, ill-fitting clothes, lab values, serum albumin is appropriate, cholesterol, dysphagia, these types of things, as well as serious infections of pneumonia, sepsis, or pyelonephritis. These are findings which are commonly associated with decline in function and then a possible terminal prognosis. We also have worsening symptoms. Those are signs. These are symptoms. Dyspnea, increasing respiratory rate, intractable cough, nausea, vomiting, poor response to treatment, intractable diarrhea, and pain requiring increasing doses of major analgesics more than briefly. So we have signs that are showing a progression of disease process and lowering of function. And then we have symptoms reported. And then we also have progression of disease. Let's see, worsening signs. We also have blood pressure variants here, development of ascites, development of edema, general weakness present, changes in level of consciousness, cardiac condition, effusion, venous arterial lymphatic obstruction, all these types of things. These are all taken from an LCD as examples of signs, measurable objective content that you can show in your record to support terminal prognosis. Then you have worsening labs. Lab testing is not required to establish hospice eligibility, but it does help. Oxygen saturations decreasing, certain other liver functions, calcium, these things, tumor markers, progressively decreasing serum sodium. So there are certain labs which are deemed to be prognostic indicators. Look to the LCD, see what which ones apply, see what you can actually document in that record to support your claim. Scales, progression of findings. Karnofsky performance scale, not very useful in a way because, basically you're going in 10% increments. Palliative performance scale, under the PPS, you have the 5 components, document any decline in each of the 5 components. Functional assessment staging, the FAST. It does specifically say it only applies to Alzheimer's, but it's generally also considered to be in a way applicable to all types of dementia. Progression to dependence with ADLs, the 5 ADLs, ambulation, continence, transfer, dressing, feeding, bathing. A progression to dependence on these can show progression of disease. Progressive stage 3 or 4 pressure ulcers, not 1 or 2, not stage 1 or 2, but stage 3 or 4 in spite of optimal care. And then increasing, hopefully they don't have a lot of ER visits if they're in hospice, hospitalizations or physician visits. So basically need for emergent care. Then you take the part 1, and then you layer on part 2, which are non-disease specific baseline guidelines. You should meet both of these, which is dependence on 2 or more ADLs, ambulation, continence, transfer, dressing, feeding, bathing, as well as a Karnofsky or PPS less than 70%, or really both of them. And then certain ones like HIV, stroke, and coma may have a lowering qualifying PPS as specified. But basically, you want to show decline in ADL, low Karnofsky, signs and symptoms so far. Then you layer on comorbidities. These are identified factors which can also contribute to a decline in overall status and terminal prognosis. And COPD, congestive heart failure, pretty common, diabetes, neurologic conditions, including stroke, Parkinson's, multiple sclerosis, renal failure, liver failure. If any of these are present, identify them in the record, because these can also contribute to, again, a terminal prognosis conclusion. Then you go disease-specific guidelines. We have the first two parts, which are really applicable to all conditions. And then the LCD gives for certain diagnostic areas like cardiopulmonary, neurological, disease-specific guidelines, which are deemed to be like, for cardiac, New York Heart Association, for, again, dementia type, they'll list the FAST, these types of things. And when you use those, you're giving a good picture: signs, symptoms, comorbidities, disease-specific findings that you measure initially, and then chart that over a period of time, and then that will support ongoing hospice terminal prognosis. Also, going back to GIP, because remember, this was like basically one of your highest risks right now. So some findings here is only use GIP or continuous hospice care, level of care, when the need for it is established. It should not be a routine GIP admission bridge between a hospital discharge and admission to hospice. Use guidelines and checklists, which are provided on all the MAC webs, or yes, the administrative contractor websites. I also have material available. If you were interested in that, you can be contacted in relation to use of guidelines and checklists for continuous or higher level of care, GIP. When the instability is no longer present, transition the patient to most appropriate level of care, most likely routine level of care. Communicate with facility and staff to manage the level of care service, especially facility staff. Collaborate with those facility staff to ensure their charting is correctly identifying key findings which are going to support your service. They're not charting the patients having no problems shift after shift after shift, and you're going in and trying to establish that they have an uncontrolled symptom that needs to be managed. And then hospice GIP and continuous home care is an active condition. If the condition is resolved, get them off that service and go to routine level of care. If you're not showing instability of function or content or status, then really they don't need to be on that level of care. Keeping them on raises your risk of medical review significantly. So let's go to the next part about when you get an ADR, the response part of the presentation today, which is assigning. Okay, so you get an ADR of some type. You triggered one of these reviews. So when you get them, assign a lead ADR. Choose an administrative member or nurse to lead the task, the response, watching for new ADRs, monitoring the status of what you have responded to, and ensuring documentation submitted in a timely manner. The number one reason for denial of claims, almost 40% of ADRs issued nationally are never responded to. They're just, agencies are just giving that money back, hospices. So we want to respond to the ADRs. Check for ADRs, work with the ADR lead to create an internal process to check on them at least once a week. All those MACs have a website. You can basically, billing can just check and see what claims are in ADR status. Note when an ADR is due, so you don't send it late. Double check the documentation that is requested, and that you're sending everything that is requested. An ADR for GIP level care is very different than an ADR for routine level of care. Organize the documents if you're submitting more than one ADR. Again, clearly separate documentation for each claim. And then what you need to do to respond to an ADR. What you need to actually submit for an ADR. The actual ADR request itself, the election statement. Remember I said notice of election is a baseline document needed for all hospice service. The addendum as requested and as appropriate. The initial plan of care you established, and then the ongoing plan of care up to the period at issue. So basically you may be ADR'd for a month now for a patient that's been on service for a year, is you may be sending documentation of CTI, face-to-face, and plan of care updates from start of care to present, even though it's not specific to the dates of service in question. Because hospice is basically viewed to be a progression of service, you'll be submitting additional documents between start of care and dates requested. Physician face-to-face documentation, physician orders, IDG notes, and also it's very specific. Most ADRs will say this because it's a calendar month generally being pulled, is that the IDG in the previous month that would go into this month at question should also be included, so that you're showing a progression of documentation. They're not just you're showing a progression of function, service, assessment, these types of content. So again, the key here is hospice, in many ways, the ADR sends many documents not within the specific month in question that's being pulled. You always send the initial assessment that's pertinent to the billing period, visit notes that occurred in the billed period of the month, physician visit notes, relevant documentation, and the admission assessment. So that's what you need to send for an ADR, keeping in mind you will send many documents not within the specific dates requested. Responding to a GIP or continuous home care ADR, facility records are a key component there. Look at them, see if they help your case, of course. These may also include narrative notes, orders, assessments, communications, care plans, physician notes at the time they're on GIP. The easiest way to have it in your record is when that patient is on GIP, get the documents immediately or as soon as possible after, so it's in your chart. So that if you get an ADR on a year-old GIP patient that's been in service GIP a year ago, you're not having to try and go to that facility and pull their medical records. It will fail almost every time. And then tracking logs showing non-nursing and nursing service to show you met your 50% nursing requirement for continuous home care, and then document the level of changes in detail here. So in conclusion of today, review the National Coverage Determination, the Code of Federal Regulation, Benefit Policy Manual coverage requirements. Then look at the appropriate local coverage determination that applies to your particular administrative contractor and would apply to your patient base, but really look at what's in the LCD. Review any other available prognostic guidance that's issued by the MAC. Then in-service staff on the content, especially on two things: the notice of election, the admission requirements, and then significantly the local coverage determination guidelines. Those should be integrated on the start of care, on the face-to-face, on the initial assessment, on every IDG they should be considered as appropriate, on visit notes that might be appropriate. I mean, those need to be embedded in your charting, because if you can keep identifying LCD appropriate signs, symptoms, findings, labs, content as present, then you can make a substantially positive case that the beneficiary has a terminal prognosis of 6 months or less, and they are appropriate for hospice. Getting back to the slide here, number 5, check all technical requirements are met at admission and every recertification, including a face-to-face encounter. Train, integrate, and implement the LCD guidance, as I just said. Review agency EMR. Look at your electronic medical record system for meeting technical requirements. Some of these are horrible. They're home health processes or systems which were just slapped onto hospice, and they're difficult to read and they don't present well. Is really evaluate, is your EMR readable and understandable to a reviewer? And how well is your EMR pointing your clinicians in the direction of charting hospice appropriate content and LCD content to ensure you have a good prognostic guidance? And then conclusion, when ADR is received, respond timely and thoroughly, read the ADR, look at the due date, use guidance for what provided by the MAC for what needs to be presented. So that was my short view today of the financial risks, really, of the medical review environment, the types of review occurring, the responses needed, and the important clinical documents that need to be present, and then also the importance of using the local coverage determination as both training tool for your staff and charting tools for improving hospice documentation. So this is really a financial one here. But hopefully next month, you guys are all on board with the next webinar, which I will not be presenting, but it's on cost reports and CAP reports. And because there's always more to do in the hospice world. And then February 8th, there's also the Super Bowl of hospice knowledge. So I appreciate this. Really ends my presentation today. I'll certainly take questions. And I will turn it back to our moderator. I appreciate your attention, and I'll just leave it up to questions now. Thank you.
If you have questions, either drop them into the Q&A box, or you can raise your hand and you'll be unmuted so that you can ask those verbally. One question that was in here, Joe, was with PPEO being the newest review format in place, what have you started to see in regards to PPEO activity or responses?
None have crossed my path yet, so I'll be upfront on that. I
Mhm.
do see it though as a significant risk because basically it'll put you on some form of very high level ADR review for your claims. So, and I mean, it is limited at least it's really limited to certain states and then new hospices or change of ownership. So, um, if you fall into one of the four states identified, Arizona, California, Texas, I mean, if you fall in there, then basically your defense against it would simply be using those LCDs in your charting to support you have a terminal prognosis. But again, I have not seen the implement yet. I think when it does occur, it'll be a tremendous burden on the hospice because it'll be a significant number of ADRs received. And there's no actual statutory requirement for how long it can go or how short it can go to get you off this review. So it's kind of a open book right now as for what they're going to do with it. But if you're not in that, if you're not in one of those four states and have not had a change of ownership, that's really good news for you in that, basically you have no risk involved with it. If you are in one of those states, um, it would just be use the LCDs in all your prognostic charting, and that would be it. And then if you need help for ADR response, then reach out because you don't want to be late. That would also be an indicator, a possible indicator that you are not an above board hospice because they're saying you need additional scrutiny. We asked for records, you didn't send them. Obviously, that must mean that you don't exist or you're not doing the right job. So responding to ADRs is a key component for that. So that'd be all my prospective things I would do, but I have not seen any PPO activity initiated yet that's crossed my path.
Got it. And I know we're a little over on time. Does anybody have any other questions for Joe before we wrap up? If you do, you can always submit them after, and we'll make sure that those get Joe's way, so that he can respond accordingly. And also the contact information on this slide works as a follow-up to get those questions to Joe as well.
Yes,
Thanks
I'll be very
all.
happy. I'm sorry, I'd be very happy to respond to any other questions that came up. I was ripping through information today, and certainly I want information out there so you guys are compliant, appropriate hospices who have excellent outcomes from any medical review. So I'm happy to respond to questions.
I just find it unbelievable that 40% of ADRs are not responded to. Um, that's a crazy statistic.
That's just throwing the money away.
Well, thank you, Joe. Appreciate you running through a lot today, and thanks all for attending. We will wrap up, and again, you'll get this recording and deck as a follow-up. Thanks all.